Hi, good morning. I'm Dr. Christy Sutherland. I'm out here in Vancouver, BC, on the unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations, and I'm grateful to be here. I'm talking about opiate use disorder and trying some novel fentanyl-based therapies for that. So for my disclosure, I've had CRISM. I've been involved in CRISM grants and been the site PI for Optima and Presto, which were national Canadian trials about methadone and Cadian. I've had honorarium for speaking, never for any pharma companies. I do consulting for often other nonprofits such as AVI and Ask Wellness, where they pay me for my time to help them set up programs. And then my big bias is that I've been working in the downtown east side of Vancouver for 12 years as the medical director of the PHS Community Services Society. We're a nonprofit and we do housing, programming, managed alcohol programs. We have a low barrier bank. And definitely working in the downtown east side has changed me as a person. So that is very much a big part of my bias for my clinical practice. And then just to manage this bias, I'm going to highlight that what I'm talking about today mostly has no evidence at all. So you can proceed with caution. So the downtown east side has been so rough these past few years with the opioid overdose crisis. I'm sure you have all felt the same in your communities with the amount of death that's happened. And so that really has spurred us as a nonprofit to want to offer more interventions for our patients. So we first started IOT just like 3 months after the Salome trial was published. And we did this inside housing. So as often happens in nonprofit, you have the funding, but you just have a lot of love and a lot of enthusiasm. And so the Sweet Nursing team at the time, we put together a protocol. We started just one person on IOT inside one of our housing projects. And it worked so well. And so I was like, oh my gosh, we have to expand this. So we then got funding to put it inside an overdose prevention site. We started our tablet program, so TIOT, we decided to call it, a tablet injectable opiate agonist treatment program inside an overdose prevention site in 2019. We also started doing fentanyl patches this year. And then this past year, we've started Fentora tablets and sufentanil IV. So there's no evidence, but we can sort of extrapolate from the IO literature is how I feel as a clinician for why I'm prescribing in this way. There's one really nice qualitative paper. A lovely PhD student came and spent months inside our TIO program doing interviews and observing, and it's quite a beautiful paper. And all of our current programs are being studied by the BC Centre on Substance Use. Where there is a lot of evidence is for OAT. We know that OAT is the backbone of treating opiate use disorder, and it's what prevents mortality. And there's lots of evidence for heroin IOT. There's one paper that shows that hydromorphone IOT is non-inferior to heroin. We have hydromorphone at our clinics because there's challenge with the supply chain in Canada for obtaining heroin. So I'm sure we've all seen this slide before, that there's a continuum of care for opiate use disorder, that patients can move along this continuum as they stabilize and destabilize, or if their life changes, like if someone moves out of town and or wants to switch to Suboxone because they have a job and they don't want to come to the pharmacy each day. And then sometimes people destabilize, they want to restart on Cadian and then move on to buprenorphine as well. I don't know about you guys, but I find that this is not enough anymore for my patients. I have found that I can't leave my work at the end of the day because I just am walking through a group of people on the ground and I'm worried that everyone's overdosing. So I have to get off my bike and nudge each person with my toe and say, are you still alive? Are you still breathing? We do overdose interventions outside my clinic almost daily. Sometimes we have 2 in one day. Sometimes we have 2 at the same time. Sometimes it's pouring rain. And the nurses and I joke that we need those hats that have umbrellas over us for running all of the codes that we need to run. It has just been so sad that we have really felt the need to offer more to our patient population. So let's talk a little bit about the evidence for IOT, that really we all know patients who have not benefited from first-line medications, and that's for a variety of reasons. They still have cravings, even when you get them up to 150 of methadone, and sometimes I'll split the dose as well, and they still just have cravings. It can't meet their opiate need. Being unable to reach a therapeutic dose, I'm sure we all have a patient like that who you restart them on methadone over and over and over and over, and they just can't get those 3 doses in a row to titrate. And then sometimes people have very poor side effects from methadone. They have sedation, they have that methadone foggy feeling, they just don't like it at all. And and that these individuals are at increased risk for harm, including death, non-fatal overdose, bloodborne infections like HIV, violence, and arrest. So for heroin prescribing, it's been going on for a long time. It is not a new intervention. In the UK, it's been going on for more than a century. And the first trial in Switzerland was in 1994, and it's been standard of care for treatment of opiate use disorder in Switzerland since 1998. And this is in the context of a very robust methadone system that's low barrier and quite available. There's a Cochrane review about it, more than 10 years old now. So to compare heroin maintenance to methadone treatments for opiate dependence regarding efficacy and acceptability, retaining patients in treatment, reducing the use of illicit substances, and improving health and social functioning. So 8 randomized control trials. There's more research now since this Cochrane review came out. And that the patients who entered these trials had previously tried methadone. I remember that was a big issue for clinicians at the time here in Vancouver, worrying that people would enter these trials having never had a trial of OAT. I have to say, in Vancouver, running these novel programs, it's very hard to find someone who hasn't had a trial of oral OAT. And if they haven't, they've had certainly many opportunities. So if you have a patient who's just declined OAT since the 80s, probably OAT is not the treatment for them, and we shouldn't make them go through a trial of a medication that they don't want in order to move up to the next intervention. So they compared heroin injectable head-to-head to methadone, and that all the heroin doses were observed. And there's no mortality reduction in the Cochrane review, but there has been paper since that shown mortality reduction. And then there's the greater adverse events related to the study medication. So heroin is quite potent. So they had some seizure and some in the heroin treatment arm. And then the results of criminal activity incarceration were not possible to be pooled. So social functioning improved. It's no surprise as clinicians that we see when our patients get stable, they reconnect with their family, they start a job, they start school, they do all kinds of positive things. And that when they pooled all of these trials, the direction of effect remained in favor of heroin. So this really is an intervention for people who are struggling with the current options. It's quite an intense intervention. It takes a lot of time. And then people are given a dose of methadone at night. So similar to our programs that people are paired with oral agonist treatment. Most people don't stay on it forever, many do, but the average time is only 3 years, which I think is pretty short for this kind of intervention. People stabilize in a dose and remain on that dose. I think sometimes clinicians worry with programs like this that patients will go up and up and up until the end of time, but patients don't. They get to a place where they're comfortable and they say, I'm ready to stop here. I have found in my experience that it's very similar to methadone, where I'm always wanting my patients to go up on their methadone. And they say, no, I'll stay at 50 because I want to come off of it. But I want them to be comfortable in the middle. I'm like, I want you to sleep. I want you to have some time away from injecting. Like, I want you to be comfortable in the middle. So let's go up to 100 and then you can go down. They're like, no, I'll stay at 50. And I find that is an ongoing conversation I always have with my patients. And it was often the same on IO, where I was like, let's go up on your dose. You look a little, you're not as comfortable as I want you to be. I think you should be. Like, I would be on a high dose. And they're like, no, I'm going to stay down here. And that many patients transition to oral treatment, but in the literature, there's a small subset of patients that taper and go on no opioids at all. There's no detrimental effects on public safety or disorder, and people on HAT, it's no surprise, decreased criminal behavior. And then it's cheaper for the system to provide this intervention than not. We see it in crime. So as clinicians who work with people who use drugs, we save the system a lot of money. But that money is saved in the criminal justice system, and then that money doesn't come back to healthcare or to social programming to be then spent for the patient population that we care about. So nice connections with primary care, multiple interactions with nurses each day, and then you can have an interdisciplinary team. And then another thing is that it decreases the illicit market of opiates, so it decreases profit for organized crime. So sort of all that to say, that was like the evidence that was marinating in our minds when we were thinking, what in the world are we going to do here? As we came to work each day and just intervened in overdoses. Because we found that the street supply of fentanyl meant that the interventions that we had were not working anymore. People were still in withdrawal. We'd have them at massive doses of IOT combined with methadone, and they were still dope sick. Patients are saying, I would like fentanyl. And I was like, oh, that's very reasonable. You're using fentanyl on the street, and then I'm trying to here convert you over to a different medication. It's important to note that in the heroin research, heroin was the drug that was used on the street. And so it made sense to switch them over to the same drug. And then we have this benzodiazepine contamination of our supply. And so sometimes my patients would come in and say, I'm in benzo withdrawal. I want to stop using fentanyl. I'm trying to get up to a good dose of methadone, but I feel achy from the benzos. And then I think as well sort of about justice, and that I feel so privileged as a person who really likes to drink wine and go on wine tours, that when I drink, it's a social situation. I know the substance I'm drinking, I know the dose, and I have clean supplies. And if a vineyard killed a bunch of people, it would be shut down. And I think about that luxury and I appreciate it. And I think about how can we replicate that for our population. And that I love this quote, for every complex problem, there's an answer that's clear, simple, and wrong. And I think that the overdose crisis has really brought this to the fore, because the clear, simple, and wrong answers for people just not to use drugs. And that's not a realistic thing. Using drugs is part of being human, and it's a normal part of life. But we've criminalized drug users and created this toxic drug supply chain that's controlled by organized crime, and that's killing people. So it's quite complex to unpack. And just saying to people, stop using drugs and then you won't die is an insult to them, really. So we wanted to make these fentanyl protocols, and we sort of felt we had a leg to stand on based on the IOT literature and that the drug street supply had changed. So we were just changing to match the street supply, just as that heroin trial in Switzerland in 1994 matched what was on the street. Fentanyl is a challenging molecule to use. The molecule itself is very large and it requires a large amount of solution. And that the available formulations of fentanyl are for the operating room or individual patient pain. And so, we would do the math out for the equivalency of what we would need, and it would be 20 mil syringes, like a barrel, like that no one could really inject in an IOT room. And then the physical amount of granules per dose is very small. And so we're working now on fentanyl capsules of powder, but to get the same amount of granules in each capsule, we're working with a compounding pharmacy, is incredibly challenging because the granules are so tiny. It might be 1 grain of sand per capsule. And so I really understood more why organized crime is not able to do this well, and why it's killing so many people, in that you can't order your fentanyl off the dark web and put it in your blend tech and mix it up into baggies and have the same dose in each one. It's a massive process. The other challenge was that fentanyl, when it's used in the operating room, they might use 12.5 micrograms, whereas my patients have been taking like an 8-ball a day. So the dosing that fentanyl is made from pharmaceutical companies, we didn't feel was adequate to have. We were stumped about how can we get an adequate dose of fentanyl to our patients with a reasonable delivery mechanism that's safe for our patient and that operationally feasible. So much fentanyl for my colleagues who do inpatient medicine, they would hang it in mini bags in the ICU and the nurse would run it into a line. We couldn't do that in community. So that's when we turned our mind to the fentanyl patch. And so, because we wanted high dose that was for community that could be reasonably administered and titrated. We also looked at the medication called Fentora, which is a sublingual fentanyl tablet for people in palliative care, sufentanil, and then our regular programs continue to operate. Whenever we create protocols, I have a lovely committee. I feel very grateful for all of my colleagues. We involve people with lived experience every step of the way. We have physicians, nurses, and pharmacists, and external reviewers. I always ask a palliative care doctor to look over our protocols because they are quite comfortable often with fentanyl and with rotating between opioids and complex opiate regimens. That you want every individual to practice to their scope. And so when thinking about a protocol, you want it really laid out, that it's quite clear for the college and regulators that everyone is practicing within their scope for it's well defined what the scope of practice is for each person. So you never want to give someone a role that would put them or your patient in danger. So for the fentanyl patch program, we just started with 6 patients and we just put it inside our clinic. We have an LPN 5 days a week, and we just thought, let's start a couple of people on the fentanyl patch here at the clinic and see is evaluated. So it was entered into the BC cohort study of iode. So the lovely researcher just scooped up those patients and put them into her cohort. It was so successful. People stopped using non-prescribed fentanyl. They reported feeling comfortable and well, went back to school, maintained housing, connected with family. They'd bring in their art that they had created. It was so beautiful to see. People said it was similar to muscling fentanyl. So there's no peak and trough like there would be in iode or even for methadone or for drugs that you use on the street. It's just at steady state. The fentanyl patch is nice because people can convert over from Cadian. And you can do a cross titration for methadone, but we never did full conversions over from methadone. And then sometimes patients would start in the hospital. So our colleagues on the inpatient addiction medicine team would have someone on a fentanyl drip, and then before discharge, convert them over to the patch. This has been a challenge to then connect them in community, but it's certainly lovely when someone's already been through the titration because the titration is quite slow. So then we get money from Health Canada, and we've been scaling up this intervention. So we've learned a lot doing this. That, well, you know, always when you're starting something new, you're very conservative. And so we've made the titration faster, the starting dose higher, and then for missed doses, how you do the dose reduction, we've made that lighter over the years. Usually we try to extrapolate from methadone. So with methadone, you miss 3 days, you get down 50%, you miss 5 days, you start back at the starting dose, which for us is 40 milligrams. But there's no literature to guide how to do this for fentanyl patches. I'll always remember a conversation I had with a palliative care colleague, and I asked, like, what do you do about missed doses? And he said, what do you mean what I do about missed doses? And I was like, oh, when your patients miss their patch changes, how do you adjust the patch dose? And he was like, that's never come up. Like, it just doesn't happen in other areas of medicine. So we are sort of trying to figure out how to be safe for our patients. There's no maximum dose for our protocols. We try to avoid ever having a maximum dose because who am I to say what someone's dose should be? But some people are limited by skin area. If you get above 1,000, it's 10 patches. So sometimes it's on both arms or on their back. And we did Monday, Wednesday, Friday patch changes instead of every 72 hours. So that gives people a predictable schedule for their life, that it's the same patch change day every week, or rather than changing the day of the week if you go every 72 hours. And then just operationally for the nurses, it works much better. It's quite a slow titration. So we start people at 50 and we go up by 50 every second dose. So you need 2 doses in a row at a certain dose before it go up. I think some of my colleagues in Vancouver who have taken on this protocol go up a bit faster. There's not a ton of euphoria from the fentanyl patch program. So I know some people do like that up and down of euphoria, and then with hopefully not withdrawal, but they like the ups and downs of the fast acting medication. And the patient has to be quite organized. We try to give people chances to start the program, but many times patients, like if they're homeless or just a bit more chaotic, it can be hard for them to go through the titration, and then it's very frustrating for them as you can't go up on the dose because of missed doses. So it really is not a low barrier program despite our best efforts. So then we thought, what else can we do? And so we talked with our pharmacy colleagues, and we decided on sufentanil, which is a sublingual fentanyl tablet. And this was created for palliative care of cancer pains. We thought it would be potent enough for a population. We created a titration where you go up by 200 micrograms per day for this BID dosing with no maximum dose. So people are up to like 2,000 micrograms. And then we also created a PRN program so that you could come and go as you like with no missed dose protocol and no titration, and just be on 400 micrograms. PRN programs are nice for flexibility. They're certainly nice for writing the prescription because you're not rewriting scripts for titration. But it's hard to find that right dose that's high enough to meet the opiate need, but low enough that it's safe for them to come on and off in a flexible manner. The other medication that we chose to start was sufentanil. I'm sure many of us have been using sufentanil for years for wound care and for palliative care. it just makes people feel so much better. So in our clinic, we've been using sufentanil for wound care for years, and people would come in for wound care, get their sufentanil, and also be out of opiate withdrawal and look so good and feel so much better. And so I thought, oh, okay, well, this is a medication I feel comfortable with as a clinician, and that I have seen people do well on this who are in withdrawal, come in for wound care, we get them out of withdrawal, and then comfortable for their wound care process. It's a high potency for a low volume of injection, so it's more potent than fentanyl. There's an option for a sublingual route. It's always nice to have multiple routes because in a protocol, you never want to make people inject. You know what I mean? Like, so for IOT, sometimes people will take it sublingually because I was like, who am I to tell you have to inject this medication when you don't want to inject something? You can take it a different way. And so Sufent is nice for that secondary route, especially for smokers, people who are not IV drug users. In the past, they've only had oral, like methadone, Suboxone, or Rocadian as their options. And so it's nice to have a way, like another medication that they can use. And then the maximum number of doses is determined by operating hours, not the half-life of the medication. So sometimes for, sitting down with a pharmacy team and figuring out how we're going to do dosing, that it's the business hours that sometimes forces your math rather than the pharmacokinetics. And we do test doses for tolerance. So when you're creating a program, one of the things you want to secure is the supply chain. So you want to make sure that you don't start prescribing sufentanil and then run out of sufentanil and have to stop your programs, or that you cause a shortage of sufentanil for hospice or things like that. So we will always work with PharmaCare to make sure that the supply chain is in place. We actually had to delay our sufentanil program by almost 6 months because the ICU was needing the sufentanil. So, and then think about the time to peak and that half-life of the medication. You want to think about the ease of medication administration, the nursing time to prepare the medication. So for our IOT program, each person's on an individual dose and the nurse draws up the dose when the patient presents. Whereas sufentanil, most people are on 250. And that's one vial to draw up rather than multiple vials. And it's one vial per dose, so it's not multi-use vials. So just thinking about your capacity and how much nursing time and nursing work that takes, and then how many moments for error potential there are. So you want things to be like quite streamlined for your nurses so that they're feeling safe in their practice and that it's you've thought from a systems way to prevent medical error. And then how far between the doses and how many doses in the day. And then the narcotic counts is another big thing to think about that, as a physician, I never thought about, but certainly my nursing team and pharmacy team, we spend a lot of time talking about narcotic counts. Like the blister packs were packed in 31s. And so how do you count if you have like 4 blister packs, you're multiplying by 31 for those nurses doing the narcotic counts. So you want it to be easy to make sure that your narcotic ins and outs are well accounted for. And then you want to think about your titration and maintenance versus a PRN program. There's benefits to either for different populations. The PRN Tio was very popular. The PRN sufentanil has been very popular, but not our Fentora program. When we first started Tio, it was the tablets that people were injecting. So it was not the route that the medication was indicated for. And so it had to be under the auspices of research for the College of Pharmacists to allow us to administer tablets in that way. I had felt comfortable with that because patients have been injecting tablets since the 90s, and that's what the patients were specifically requesting, and that they were already at risk of things like Talic lung. So I wasn't giving them a risk that they didn't already have. So with the sort of balance of harms, we felt that it was a lower harm. But that's not true for Fentora or sufentanil. So all of our new programs, the medication is administered the route that it's indicated for. You want to think about storage and shelf life. If you have pre-drawn up syringes, there's a much shorter shelf life than if you are having your vials that you draw up. And then operational hours, that it takes a lot of admin work and a lot of narcotic counting to keep these programs safe. So we adjust as we learn about the protocols to, if patients are still sitting in front of you in absolute withdrawal, so uncomfortable, you want to go faster as a clinician. So there's always room for physician discretion and case-by-case planning. All of our programs are co-administered with OAT. This is the thing that has evidence. Our programs are being evaluated, but they do not have any evidence yet. And so really, I want patients to be on a nice dose of OAT. The fentanyl patch is sometimes the exception because you would be prescribing 2 long-acting opiates at the same time. So, but for a lot of patients, they like that last bit of methadone. So you'll do a cross titration for the fentanyl patch and you get them up to 800 of the fentanyl patch and down to 20 of their methadone. But they just want to keep that last 20 milligrams. And I think that's reasonable because of the mechanism of action that's unique to methadone. Everyone who's in our programs is engaged in primary care. So we offer contraception, pregnancy testing, blood work, vaccines, blood pressure monitoring, chronic disease management, and wound care. And then their medications are co-administered with the opioids. So we have really great success. We'll do a blitz of Hep C treatment, or people have really good suppression of their viral load if they have HIV. We work very closely with our nursing team. And so we have a doctor of the day system where the nurse leads the methadone and Cadian titrations, and then the doctor of the day signs off on them. Because I found that, it's very rare ever that you would decline to increase someone's OAT unless they were sedated in front of you. And it's pretty easy to have a nurse say, you're too sedated, you can't go up on your OAT today. And so we created a template for the nurses to use and like a decision support tool and a doctor of the day system where the nurses were the ones who were offering the patients the titrations, filling out this template, and then the doctor of the day would sign off on each of them. I just like this slide because it makes me think about like what is going on? Like, how did we get here that our patients are bearing the burden of this danger that is a system that is around them that is causing danger, and yet they so often are blamed for the danger that they're in, and that they're so often just told to make better choices when really that misses the point. And that a program will never solve a problem that's created by policy. So I love running these programs. I love it when my patients tell me stories about how they feel better. I look forward to the day that I'm not resuscitating people in the alley multiple times a week. We all do. Like we want this overdose crisis to be over, and that I love making interventions that will help people. But probably there's been hundreds of people who've moved through my program over the past few years, and it's been a joy to take care of them. But that I am, I think maybe we all feel this way, that we're sort of like running in quicksand because it's policy that's created this problem in the first place. And that I'm getting government funding to try to solve a problem that I feel our own government has created. So I just wanted to talk a little bit about that, and that we are in a really bad situation where how drugs interact with society, where we are in an unregulated illegal profit, where organized crime is controlling our supply chains, is not being taxed, is not being regulated. And what we really would be so much better for society to have a public health model. So yeah, I'm sure you've all seen this U-shaped curve before. The unregulated legal profits on the other end is also something to avoid. That's like tobacco in the 60s, where, with Joe Camel and sales and sponsoring jazz festivals, and that you don't want unregulated legal profits because that also leads to harm for people. We want this public health model. And what does that look like? And then I think it's so complex because drug policy covers so many different areas. Classically, we just think about drug policy as the law, like lawmaking and interpretation of law and judicial decisions. But really, that it crosses so much of society, like housing and shelter, social policies, resource allocation, how we plan our cities, how we spend money and plan our healthcare system, school planning, work safe, like employment issues with drug use, that it's such a complex, overarching framework for how drugs and people interact. And that the outcomes of drug policy are quite racist, that if you use drugs, the outcome of your drug use is determined by your race, your gender, your wealth, your social capital, your health status, the purity and strengths of the substances, and the context of where you use. So all drugs carry risk, those that are legal and illegal, but our patient populations bear the burden of criminalization in addition to the risk of the drugs that they're using. I like this guy. I don't know if you guys follow him on Twitter, Ryan Marino, but I think that this really encapsulates the crux of the issue, that many people use drugs, but most people who use drugs are not criminalized. And that my patient population is being arrested every weekend, disruption in their OAT, disruption in their antiretrovirals, disruption in their housing, and disruption in their lives at a huge amount of cost. Whereas there are so many people who are not criminalized for their drug use. And then this often falls along racist lines. We know that alcohol prohibition did not go well. There's Al Capone. It was made, would have been almost more than $1 billion when accounting for inflation through selling alcohol during prohibition. We know that didn't go well. So it's funny that we still are persisting with other drugs. This was a quote from interviewed with John Ehrlichman with a reporter. You may recognize his name because he was involved in Watergate. He was one of Nixon's top advisors, and he went to jail over Watergate. And this reporter came out to his house and sort of knocked on his door. And John didn't really want to let him in. So he sort of was at the door and just spoke through and said, you want to know what this is really about? The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be against the war of Black, but by getting the public to associate the hippies with marijuana and the Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. I remember when this came out and I thought, oh, this is a mic drop moment. We will end the war on drugs now that the person who was involved in the creation has so clearly laid out these malicious motives, and that it had nothing to do with the drugs. It had to do with oppressing people. And yet it didn't change much. So I look forward to a future where physicians are not trying to scramble to create these protocols and these programs. That I hope that our government will roll out a public health model for drugs so that people can have safety and access to things that they want to use and not be overdosing in this way. So although I love running these protocols, I don't think that they're the solution to ending the overdose crisis. And then if you want to chat more or if you would like me to help, I'm always interested in working with others to set up protocols. You can give me an email. And that I think that this is an iterative process, that it's not going to be a one-time thing where the Prime Minister will announce that we're going to get a legal regulated market. It's going to be many years of work over time. Thank you.